Good afternoon, and I'd like to welcome you to our session, Finding the Common Beat Towards a New Vision of Collaboration to Improve Access to Medicines. I'm Natasha Atsopardi-Muscat, Director for Country Health Policies and Systems in WHO's European Office, and it is my pleasure to welcome you to our session today. I am joined by Hans Kluge, Regional Director for WHO Europe, by Dr. Bjorn Inge Larsen, who is the Secretary General for the Norwegian Ministry of Health and Care Services, and by Clemens Auer, who is a special envoy of the Austrian Federal Ministry of Social Affairs, but also the president of our European Health Forum, Gastein. And of course, today the focus is going to be very much on sustainable access to novel medicines. This is critical for us to be able to work towards the universal health coverage and sustainable development goals. And it's being particularly challenging when we talk about novel medicines, because despite this goal being shared by virtually all actors, achieving it in practice has been proving quite difficult. Of course, patients, health systems, and governments expect the right to reasonably priced medicines to meet their needs, whilst investors and the pharmaceutical industry expect to earn sufficient profits to compensate for the risk inherent in developing and manufacturing these medicines. So, working to achieve this goal is going to require much more solidarity, transparency, and coherence on a number of controversial topics, the so-called elephants in the room, which we need to start crystallizing and unpacking and finding the courage together to take to the dance floor. So in this session, one of the things that we would like to do is to understand a bit better how during the COVID pandemic, we have seen examples of how this collaboration is indeed possible. And we also take the opportunity of the convening tradition of the European Health Forum, Gastein, which is to bring partners from different sectors together to discuss difficult topics, to launch a new initiative, which we are calling the Oslo Medicines Initiative. And over the coming months, this will provide a platform for member states and non-state actors to collaborate and set out a new vision and framework for better access. The session is organized in two parts. I will be moderating the first session, and the second session will be moderated by my colleague Dimitra Pantelli from the European Observatory on Health Systems and Policies, who have also been supporting us in this work. And we are very grateful for the support that we have received from the Norwegian Ministry in order to have this session today. And therefore, without further ado, I would like to introduce you to our icebreaker polling question as a practice or warm-up. So a little bit just after lunch, we ask you what music style best describes the existing situation with access to medicines? Modern jazz, funk, blues, classical, or rock? What would your choice be? Do we need a lot of improvisation? Are we straight-jacketed within very typical classical musical scripts? Is it very much rock and roll? Okay, so it seems as though it's funk, followed very closely by modern jazz, with rock following and blues and classical in the last position. But can I now ask you to answer a little bit of a more serious question now that you have had the practice? Then we have a comment already saying we can learn a lot from jazz and how to manage uncertainty. But moving to the next question, the theme of our conference is dancing with elephants. What do you see as the largest elephants in the room? You can here select also more than one answer. And funding here clearly seems to be the biggest elephant in the room. And of course, I suppose more so as we head into a difficult period ahead with fiscal tightening and economic uncertainty. I encourage you to continue to share your views with us using the chat function. And without further ado, I would like to ask my boss and colleague now, Hans Kluge, a few questions, which perhaps some I already know the answers to. But Hans, if I could ask you, what motivated you to put the topic of access to novel medicines as a high priority for your work in the coming years amidst so many pressing and important priorities?
Thank you, Natasha. Do you hear me very well?
Yes.
Great, great. And please, indeed, don't call me your boss, but your colleague, because I strongly believe in mutual learning. And it's great to see Dr. Larsen, Dr. Clemens Ower. Congratulations again, Clemens, for the fantastic opening today. And to come straight to the point, the access to affordable quality medicines is at the core of universal health coverage. And 1 year ago, I was still going around the countries campaigning, and this issue was mentioned together with the health workforce as the #1 preoccupancy by the ministers. And then #2, from the great work being done by the WHO Barcelona team on financial protection, we know that medicines is the main driver to push the people into poverty, especially the poorest fifth of the population, whether it is in the west or the east of the region. And it's an issue, as you say, within the spirit of Gastein, that we cannot tackle alone. No country alone can tackle it. Thank you.
The regional committee some time ago just approved the European Programme of Work with its title United Action for Better Health. How do you see that the public health authorities and private industry can really join efforts to deliver a new social compact for sustainable access to novel medicines?
Right, indeed, Natasha. And I'm very humbled that the 53 countries unanimously approved the European Programme of Work 2020-2025 in line with the GPW 13, which was marshaled by Dr. Tedros globally. And if I have to summarize the EPW in one word, it's the word how. How are we going as a health community to transform Europe towards better health and well-being? And the second how is to unite efforts of partners, the partnership. And there the SDGs, and you can see from my mask, the SDGs, they are giving the mandate to engage with the private sector, keeping in mind, of course, the values and principles of transparency and accountability, because I strongly believe in what we call win-win situation. We need the pharmaceutical industry to innovate, but issues like intellectual property rights can never be a barrier for any patient, particularly the poor, to receive the life-saving medicines. So I'm quite optimistic, also based on the experience I have been seeing in the COVID response now.
Very good. And coming, in fact, to COVID itself, given that COVID is so much occupying the space, the bandwidth, the time, the energy of all players, is it realistic to continue to pursue at this stage also our agenda on access to novel medicines when COVID seems to be taking up all our energy?
That's a very, very relevant question, Natasha, because ultimately there are only 24 hours in a day. But we discussed this also with Dr. Larsen and his team yesterday at our preparatory VC. We in WHO, we advocate for what we call a dual-track health system response, because there is no holding back. We need to go full force on the COVID-19 as the political and medical preoccupancy. The last 7 days, we saw 420,000 cases, which supersedes for the first time what happened at the peak in March. But at the same time, we have to move forward on the other events, and often they're intertwined. We know that 68% of our member states had delay in care for patients with chronic disease. 6 countries in the region, totaling 22% of the total infantile population in the region, disrupted routine immunization. Case notification for tuberculosis dropped to 50%. So we have to move forward and capitalize on, anyway, the fact that we became much more closer with the pharmaceutical industry in this unprecedented speed of vaccine development, therapeutics, diagnostics, to capitalize on this corporate social responsibility.
That's indeed. I mean, this is one of the things, I suppose, if we are telling countries that they need to continue to work on this dual track approach, we should be the first ones to lead by example. Let me now turn to Björn Inge. At first, allow me to acknowledge your leadership in really putting this topic on the agenda already some months ago now. And perhaps my first question to you would be, I mean, Norway is a high-income country with a well-organized health system. And I must say I was a bit surprised when I learned of your interest and initiative in putting this on the agenda. So can you perhaps share with us your motivation for placing this issue very much at the heart of the European health policy agenda?
So thank you, Natasha. As you said, Norway is a small but fortunate country. We found oil in the ocean outside of Norway, which has made Norway a quite wealthy country. So we have a high public budget for health services and universal coverage. We are a very egalitarian society, so we are trying to distribute the services fairly in the population. So everyone will get access to the same services. And it's a long time since we were able to use all good technology that would actually benefit patients. The health sector has come a long way in knowledge and technology. So there are things that we need to prioritize down to be able to provide services for all. So what is worrying me and Norwegian health politicians is that we see that more and more often we are not able to take into use new and innovative drugs. And since we know that we have one of the best financed health services globally, we're quite sure that this inability to use all new good technology will probably be the situation of most countries in the world. We have a systematic approach when we evaluate new drugs, look at the value that they provide and the cost that they come with after negotiations. And last year, unfortunately, we were only able to take on half of the new drugs that we evaluated for use in the Norwegian health sector. And that doesn't mean that we wouldn't like to use the rest of the drugs. They would be beneficial for our patients. But we couldn't take them into use because they were priced too high, even for our health budget. And my reflection on that is that we want the pharmaceutical industry to be innovative, competent, creative, and to bring forward new good drugs. Of course, we understand that they are private entities and they need to give a return to their shareholders. But we believe it should be a part of the social contract that when they do great things, that people should benefit from that, and that the behavior of the market needs to be adjusted so that people generally can use the new technology that comes. So this is not a national perspective for Norway. I think this is really a very important debate that reflects the situation for all countries. And the new with this is that it's also affecting the richest countries to the extent that it is just now.
Thank you very much for that very frank and genuine expose. I mean, I think it is quite startling to really hear that a country like Norway was not able to take on already 50% of medicines evaluated. The situation in poorer countries must, of course, be something that is already even too dire almost to contemplate. So I think clearly there is something that we need to do. But perhaps over the past months, we have seen an unprecedented amount of activity around COVID and access to the new COVID vaccines, the new treatments that might become available. What do you think that we have learned so far from these recent initiatives to try and ensure global access to an affordable vaccine when an effective vaccine becomes available? And perhaps has this pushed the issue of access to novel medicines, say for cancer or rare diseases, somewhat to the periphery? Or on the contrary, would you see the current situation as perhaps having been an opportunity to really propel us forward with more courage and conviction to tackle this issue?
Well, thank you. It's a very good question. So let me take us back to March and April, when COVID really took a grip globally. I think what most authorities and health services experienced at that time was that the market, the normal market for personal protective equipment, fell apart. The companies that normally delivered these equipment to us, they were not able to get equipment because there was a shortage globally. And I think most countries struggled a lot to find ways to provide personal protective gear to their health services, and we certainly did so in Norway. When COVID grabbed its take in India in the first round, we were afraid this was going to happen also to the pharmaceutical market. India and China are major actors in the production chain of pharmaceuticals, and I think many countries were very anxious about having a situation where the pharmaceutical market in general did not function. In reality, that would maybe have been worse than the total COVID epidemic in itself. So, and I would say I would like to give credit to the pharmaceutical industry during the period of COVID. I know that they have been working very hard to live up to their responsibility of providing medicines globally. They have refused countries to build big storages of medicines when countries wanted to do that. And that's been very responsible because they have understood that they needed to take the production of medicines to fulfill their responsibility to provide medicines to all countries. So that has been really good to see that the pharmaceuticals industry did not fall apart, and that they took a very responsible approach to delivering medicine in the global community. And my personal opinion on also the work on the vaccines just now is that we do see a lot of innovative activity on the pharmaceutical industry, and we see a quite responsible pricing policy in general. A lot of the drugs that are vaccines that are coming out now are being priced at levels that I mean makes it a realistic project to provide a vaccine for the global community. And this is a situation where the demand of vaccine is in extreme, and I'm very happy to see that the pharmaceutical industry is behaving the way they are. And I think one key in the future debate on what I think is a social contract between the pharmaceutical industry and countries and health services in general is that we need to improve the discussion between we on the authority side and this industry. And I think the experiences that we see just now during the pandemic is a very good floor to build that discussion on.
Thank you very much. And I think that this is very heartening to hear. Indeed, it has been our impression, but hearing it from people who are very much involved in the negotiating side is also good. And I would just like to take the opportunity to remind all those who are listening out there to put forward any questions or comments in the chat before I now come to our final panelist, Clemens. And Clemens, Austria has been very active in the area of medicines policy, also through the work of the WHO Collaborating Center over the past years, and for this we are very grateful. But from your experience, several years at the helm of the Ministry for Health in Austria, why do you think we need a new framework? What is working well, what is not working well? You need to unmute.
Yeah. Thank you, Natasha, for posting this question to me. You know, as you might see, my beard is already white, and I'm in this business for a long, long time. And I remember when I started working in the ministry in 2003, you know, my first task was, you know, to have an overhaul of our reimbursement system for medicines. And you know, and my catchphrase back then was, we need to create headroom for innovation, because as Björn was saying, you know, there was even 2003, we had difficulties in financing the innovation, the high price innovation, you know, and that was the time when we pushed the generics up, you know, to a fairly good substitution rate. But that was the answer back then, you know, creating the headroom for innovation was possible because we were pushing the generics. So this topic is really on my shoulders for a long time, and some of you might know that I always had a very critical and still have a critical stand when it comes to certain practices of the pharmaceutical industry. But since I'm getting older and my name is Clemens, I'm also getting a little milder, because I think we have two things. We have two problems. We still have, and Björn, you said it, and I underline that, you know, and I'm coming also from a high income country. We do have a sustainability problem when it comes to the pricing and the cost of innovation. This is a matter of fact, you know. And even once again, you know, Norway and Austria, we are the lucky ones. You know, we have good resources to finance this, but it is unsustainable. So this is one point. And as a member of the European Union, I also do know that fair and equal access to innovation within the European Union, within the 27, is not there. It's not guaranteed. You know, there's a handful, or maybe one and a half handful of member states who have the early access to innovation. Austria is always a lucky one because we are willing to pay a high price. But the majorities of the member states of the European Union has no early access to innovation. That's a fact. So the market there is not working. Problem number one, we have a problem with high prices. But in the meantime, because people like me were so successful in pushing the substitution rate with the generics to levels which are really good for the system, we also created a problem in the generic side. That's my second point, you know, because in the meantime, I observe, and you know, this might be surprising that I'm saying this, that certain elements, certain parts of the generic sector is totally underpriced. And there is no incentives anymore for some manufacturers to produce generic drugs for the European market. So this is the second problem. You know, we were so successful in bringing down the prices that there is the element that there's a disincentive to produce certain molecules, generic molecules, which are crucial for the market to be put on, because people do need them. So we have these two tiers here, you know, the low price tier and the high price tier. And, you know, I'm calling, and since Hans and I, we were pitching against each other last year in running for the job Hans has now, you know, it was always on my agenda very, very high that we have to create this new partnership between us, the public health systems, and the industry.
And Clemens, what are the critical ingredients you were talking about creating a new partnership, but what are the critical ingredients to build trust, understanding, and success in this partnership?
I think it's you know, the most critical ingredients is to be fair to each other, you know, and to acknowledge where the problems are. That we do have a cost problem, a price problem when it comes to the innovation, and also to be fair to acknowledge that we have a cost problem, a price problem on the generic side. We have to figure out the economics behind. A drug, is it an innovative drug or a generic, is not a commodity like my smartphone or whatever. We have to figure out the economics behind, and then think about incentives, because we do need innovation, and industry has to bring it to the market, but we also do need the cheap drugs, and therewith they need also incentives. So it is high time to sit on the table as equal partners, eye-to-eye level, and then start negotiating a fairer economic system behind this whole story. Without that, we are lost.
Thank you, Clemens. And I think I like very much this tone that you are setting, that we need to sit very much as equal partners, eye to eye. I think that is a very nice beginning for this initiative that we are launching here today. We have a couple of comments that have come through the chat, very much to do with economics. Somebody is asking about differential pricing. Somebody else is asking, is this about political decisions more than about pricing issues? So I don't know if any of the panelists would have a view on these comments that have come through, as the session is almost already nearing to a close, and I would have one final question for all three. But I don't know if anyone would like to comment on this issue about differential pricing, or the role that political governance and health system choices plays. Yes, please, Björn Inge.
So thank you, Natasha. So I'd just like to comment on the political system and the level of prioritization of the health sector. Is this a problem that the health budget is too low? We have been lifting the priority of the health budget in Norway for many years. It's very high. It's among the highest globally. It doesn't really solve the problem. You can have politicians increasing health budgets, and it helps in the short term. But you won't ever get to the point where you can start using all the new technology which is there with the current pricing policies that are in this market. So I would very much like to discuss alternative ways of thinking in the market, so that the pharmaceutical industry is actually making money, but that the access to the innovations that they create is much broader than it is today. I think you can have a benefit from sitting down together and finding a new way of doing this. Differential pricing, we will not exclude. That would mean we would pay more in Norway than other countries would pay. We would not rule that out. What I think is important is that both within countries, rich countries, but also in middle-income countries and low-income countries, generally we should aim for people to benefit from the innovations that are there currently.
Thank you. And perhaps on this note also, I recognize that the discussion is around also the wider health expenditures. This leads us very much into the other issue that Hans mentioned earlier on, which is about health workforce, and how do we ensure that we have a well-remunerated health workforce. So one could really widen the discussion, but perhaps really keeping to the scope and focus of this initiative which we are launching here today, which in the coming weeks and months will see us also embarking on a consultation process with member states and non-state actors. Of course, we can't commit to have a conference with a date as we would have liked to. So what we are considering is early in 2021 to have some technical sessions in this virtual format, which we think would be able to work quite well, but to continue then to have the discussion which will allow us at the right time to have a physical meeting where we can really have a face-to-face, eye-to-eye at the same level discussion. One final question for all three panelists. Let me start with you, Clemens, and I think you also have another comment, but my question would be to you, what are your expectations from the process that we are launching today? And I will be recording these because I hope that in 2 years, 3 years from now, I will be able to come back, who knows, maybe in Gastein again, to see whether we have fulfilled your expectations. So I would like to ask you, what your expectations from this process will be. What would success look like to you?
I think one part of the success is that we are really finding the formats where we have this fair and open conversation with the two sides of the table, the public health systems and the industry. And if that's possible, and I have been part of several initiatives, the Benelux initiative and the Valletta initiative, and we had this roundtables, ministerial roundtables with the bosses of the pharmaceutical industry and health ministers. But we have to build on that and continue these discussions, and if WHO is providing the framework for this would be even better, because WHO has no economic interest in this. If the European Commission is doing it, it's a little bit a different story. But I think this has to be fair and equal. But on the other hand, it's also up to us, member states, to get our act together. And some of you might know that I'm chairing this joint procurement stuff for the COVID vaccines within the European Union, and Björn Inge, you are also participating now in that process, which is a great learning example, because all of a sudden the 27 member states of the European Union are realizing that they can exercise market power if they are together. And I think that would be a good solution when it comes to innovation. Because we can exercise the market power, which would probably benefit both, the high-income country, also the middle and low-income country within we don't have low-income countries within the European Union, but with the not-so-well-off countries. So I think this to create a truly European market, with the market power of the public health systems, would also benefit the whole discussion. Now we are living in fragmentation when it comes to pricing and costs of innovation, because the industry is very, very clever in using this fragmentation. Maybe we, the member states, also should rethink that fragmentation in that particular case is not the right answer.
Thank you, Clemens. Well noted. Can I come to you, Björn Inge, now to ask you, as one of the key architects and drivers, what are your expectations and what would success look like?
Well, to be brief, I guess I hope that we still have a very innovative and strong and creative pharmaceutical industries that continues to drive forward innovations that will benefit the population, and that there is a better dialogue and understanding between the industry and us as countries, and that we are actually using the innovation so that they benefit the potential patients that need these innovation, and not only in high-income countries, but much more broadly in countries.
Thank you very much, and that is well noted too. Also, the typical solidarity. And finally, to you, Hans, what are your expectations and what do you wish to see?
Right. Maybe first, Natasha, let me explain, as I did this morning, why I'm wearing the mask, which is a sign of solidarity to the many member states, which have much more restrictive measures, particularly in the eastern part of the region. And I think the solidarity is key here. That's what we're also talking about. Concretely, for me, it would be a kind of a joint action statement with clear objectives and policy measures at the government level, but in consent with the industry. I think that would be a great step forward.
Thank you very much, Hans, Björn Inge, and Clemens. Thank you very much to the European Health Forum Gastein for having provided the support for our first part of the session. And I now hand over to Dimitra Pantelli, who will be chairing the second part of the session, which is where the real discussion starts, because it is where we have the regulatory authority, the patients, and the industry joining us. Thank you.
And I welcome everyone to the second part of the panel today. As Natasha said, we are going to have more input and more discussion for the next about an hour. And we will base our discussion already on what we heard until now. But as Natasha mentioned, this new initiative, the Oslo Medicines Initiative, is a platform for member states and other actors to engage towards a new social contract for sustainable access to high quality medicines. And the idea of the platform is exactly the idea of dialogue. And bringing this together with the 4 pillars of the European Health Forum Gastein. So we have, of course, government and administration, we have business and industry, we have civil society and science and academia. We have one partner from each in this panel, and we will hear briefly from them what their role and their perception of their role is within this new initiative, what this initiative would look like, what success would look like for them. What lessons we can draw from the pandemic, from our recent engagement with these topics for the future moving forward. And then, of course, at the end, we'll have the opportunity for questions and answers from the audience. So the way we are going to do it is that I'm going to pass the floor to the individual panelists, who I'm going to introduce in a moment. And each of them will have about 5 minutes to give us their input, short input, one after the other. And after that, we will move into a short Q&A on the panel and then to the Q&A from the audience. And without further ado, I'm very, very pleased and honored to introduce our 4 panelists. In alphabetical order, we have Sarah Garner, who is the lead at the Health Products and Pharmaceuticals Program at the WHO Regional Office for Europe. We have Marco Greco, who is the president of the European Patients Forum. We have Audun Haga, who is the director of the Norwegian Medicines Agency, and we have Nathalie Moll, who is the director general of EFPIA, the European Federation of Pharmaceutical Industries and Associations. So the sequence that I will ask the panelists to give us their input on is very similar, almost identical to the one I just presented them in, with the exception that Nathalie will be before, Audun at the end. But we will start with Sarah Garner, who will give us a little bit of an insight, Sarah, also on the technicalities of this new initiative and how we will move forward and how we will engage with each other. Over to you. Thank you very much.
Great. Good afternoon, everybody, and thank you very much, Demi. That was quite a panel to follow. So here we go. My personal journey with this issue started as an undergraduate in the pharmaceutical library, and I found a book by Oxfam called Bitter Pills, Medicines and the Third World Poor. It was published in 1987, and I'm going to give you the opening quote, which was, "Rich and poor could benefit from new drugs to treat incurable diseases, but only the poor are denied the life-saving drugs available to the rich." 33 years ago, that didn't seem right to me, and it still doesn't seem right to me. Unfortunately, now, rather than access to the poor, we seem to be having a problem with access for the rich in the more wealthier nations. So something isn't right. Rising prices mean we're restricting access to smaller and smaller numbers of patients. It means, in business terms, the returns per patient have to get higher and higher just to maintain the profitability status quo. So where are we going to end up with this? What we need to do is reverse this trend and reconsider roles of other arrangements like price volume arrangements, and noting affordability for individual countries. And for me, one of the core issues is that we're trying to fund the innovation for the future patients out of the budgets that are meant to pay for the health of today's patients. And I think until we talk about that, we're always going to have trouble funding that innovation from the healthcare budgets. And so over the years, my thinking through my work has developed, and to understand that this is a global ecosystem in which we're all partners with different roles and responsibilities. And that includes patients like you and me who participate in the trials, who take the medicines, and the public who provide the funding for it. And joint issues require joint solutions, and COVID-19 has taught us that this can happen. So I want to send a personal thank you before we start and on this launch to our panelists for their willingness to engage with this topic on the first step of the initiative. So to talk a little bit about the initiative itself, so of course access to all medicines is central to achieving universal healthcare coverage, but this project is about access on the novel products, the ones that invariably come with a high price tag. And the key aim for WHO Euro is to support that dialogue to find solutions. We've talked many years talking about the problems. We know what those are. We now need to find solutions and change. So WHO Euro and Norway are committed to providing this inclusive, neutral platform for the necessary discussions and trust building. And we had hoped to have held a meeting by now, but obviously due to the ongoing situation, it's not going to be possible. But behind the scenes, the engagement and health diplomacy is ongoing, and our aim is really that in 18 months' time, we'll be ready to discuss solutions rather than a more modest aim of agreement to work together to find those solutions. So let's aim high. So just a little bit about the process. So we've got 3 themes for the initiative. We want to really use COVID-19, the experience we've had, the positive developments, to look at examples of where we've had the different relationships between the different stakeholders. We've talked about these before, the solidarity and unity between stakeholders to resolve some of the situations. So transparency, how can we use it to build trust and support access, and then that dual sustainability for healthcare systems and the industry. So in keeping with WHO procedures, we're going to have a consultation process. So first of all, we're going to go to the member states through a virtual technical consultation, and subject to their agreement, we'll start reaching out to invited non-state actors for virtual consultations, and we're going to invite them to submit statements. And then in keeping with our commitment to transparency, the results of the consultation process, the submitted statements will all be made public, and the key themes summarised in a report. We're going to have background documents. There's a number of areas where we need to really look at the feasibility. We've had a lot of ideas for solutions. We now need to look at the feasibility of those potential solutions. So we're going to be commissioning some background documents, again, thinking through the different issues through the themes of solidarity, transparency and sustainability. And then we're going to have a technical agenda. So we had planned a joint political and technical agenda for the meeting, but obviously again we want to keep moving forward with this, so we're going to transform what was going to be panel sessions into a series of webinars and technical seminars, and invite some keynotes and panelists from across all the stakeholder groups across the WHO Euro region. And for me personally, it was a very full 2-day agenda we were looking at, and this was going to give us more time and space to discuss the issues and build on the discussions and take things forwards. And then finally, high-level face-to-face meeting, critically important for spring 2022. And at that meeting, as I said previously, the aim is to really outline a new vision for collaboration and get some commitments for what we need to do differently. So this is just the start of the journey, this launch today. WHO Euro and Norway are going to provide the framework to support the discourse, but the solutions are in the hands of the decision makers. And I was reflecting this morning on the plenary discussions about economy of well-being, and how we need to apply that concept to this technical area. So, and at the end of the day, we all have a shared objective, which is a better starting place than many negotiations have, and that's access. So I'm actually convinced we can get to find a win-win situation. Thank you.
Thank you, Sarah. That's very heartening. We have about a minute left, so I would like to ask you, for our participants who want to follow this initiative going forward, where should they be checking? And perhaps just give us a summary of the timeline until spring 2020?
Yes.
Yeah.
Good question, Demi. Thank you. So we're looking to build a separate. We'll have information on the WHO website. We're going to be looking to build a dedicated website around the initiative. It might be part of the WHO, and then also, I think this will grow. So we're looking for partners as well to take this forward. So in terms of the different stakeholders and develop discourse. So it's not one focal point, WHO and Norway really are the platform, but we want this discussion to be taken further and those solutions really explored. And in terms of timelines, as I say, we'll be announcing the scheduling, that the first thing that will happen will be the discussion that needs to happen with member states, a consultation around the engagement, the process and their comments on the initiative themselves, and then open for the non-state actor consultations, then the technical seminars, and then we hope the meeting itself.
Okay, a lot of work and a lot of interesting things to look forward to.
Thank
you very much for taking the initiative and for leading on the technical side. We move now to the patient perspective. Marco, you are the cornerstone for this. So maybe just fill us in on how you see your responsibility, your participation, what the success would look like of such an initiative. Thank you.
Thanks for this chance. It's great to be here because it's a very interesting conjuncture for being a patient advocate, historically speaking, and I couldn't have chosen a better way for my first time in Gastein, so I'm honored to start with this. I would like to start from an important premise that has been mentioned by one of the previous speakers. So the starting point for us as patients is that medicines, in our perspective, are not a consumer good like any other. Patients' lives cannot be measured in purely economic terms. It's obvious. So while medicine are an essential public good and they are also a core element of any health policy that we want to develop. They are one important part of the picture, one of the most relevant. So in this field, I really and strongly believe that there is no sense in talking about innovation if the innovation is not accessible to everybody. Life-saving medicine couldn't be considered as a commodity. That's a matter of fact. Otherwise, it's like to have a wonderful painting, but that nobody can see. And it's exactly the same example with a small but very relevant difference that very often the life of patients is at stake if they cannot get access to the right therapy in the right moment. So patients here are a critical stakeholder when it comes to develop strategies to improve access and valuable innovation in medicine. It's clear that patients and the public play different and complementary roles in the debates on access. A broader input is for sure needed around societal values, priorities, and public health needs. So when it comes to identifying unmet needs, we claim for a central role for better understanding what are the unmet needs of the patients, because at the end of the day, patients are the end user. If we really want to use, let's say, an economic language, the patients are the end user of the product. No, so the patient community today represents in a sort of collective and coherent way the different interests of these end users, if you prefer, the beneficiaries of the product. Their perspective so far is needed for filling in the gaps and for better defining the problems. And these become even more essential when we have to evaluate if it makes sense for a state or for a government to buy or to pay for that medicine or to pay that price for that medicine. We are used as patient organization to collaborate with all different stakeholders in a very ethical and transparent ways. That doesn't mean that it's always happening that we are involved. So the demonstration is coming. I mean, what we have learned from COVID-19 is that when we want, we can work together. When it's necessary, there is, although in different moments, a huge sense of solidarity. But one negative thing that has really emerged from this pandemic is that it has exposed a lot of areas in which underinvestment in healthcare are evident, underinvestment in social care, some lack of coordination. But for us, what is most relevant is that very often we have been cut off from the discussion. A lot of patients' organization in many countries has not been involved in the coordination tables, for example. This is absurd. I've seen situations in which it was difficult for chronically ill patients to even cope with the new regulations. It would have been much easier to have those patients representative at the table explaining what was the concrete problem. No? And this kind of behavior at a point replicates the problem in other circumstances. So to some extent, COVID-19 has taken us a bit back from where we were used now to be in the discussion. There are, of course, many positive things that have emerged. We have seen a swift development, for example, of e-health, telehealth solutions. And I mean, it's even ironic because it's at least 15 years that as APF we are claiming for a better use of this technology and for a coherent study of the problems that this may lead to, like privacy and so on. Now it has become urgent. We are fine with that, but we could have worked on that not in a urgent time, but with all the time for better tuning all the different solutions. So at the end of the day, by the way, the COVID has also shown the importance of an increased transparency and a better coordinated, well-coordinated public messaging. In some cases, this has not happened, but for sure it is essential, and it will be even more essential the day in which we will reach, for example, the vaccine, to clearly communicate with the public. What is this innovation? How this innovation is going to cost to the society, how it's going to be available, and with which guarantee for this. This is why we have been claiming for transparency on that. There are a lot of challenges ahead, but also a lot of opportunities that we can take. If I could say what would be the first step, well, for example, we should get to a common understanding of certain concepts like innovation or like value. My impression is that we are still somehow speaking different languages sometimes when it comes to define these. I agree. I fully support the fact that the solution won't be, it's unlikely to be a one-fits-all solution, but the fact that it's going to be complicated should not refrain us to find this solution and to get to this. Patient's view, this is the second point, should be central in the discussion, because including the patient perception of quality of life, patient-centered, patient-relevant clinical quality of life endpoint, it's an enormous benefit, not only for us, but also for the payers and for the producer. Better tuning the product, equally paying the product itself. These are values that are of common interest for all the stakeholders at the table today.
Marco, if you want to wrap up for now, and then we'll have more time later on.
I was next to do that, thanks. So I would say 4 points for closing. Ensuring alignment between the WHO European Programme of Work and the European Commission policy is essential if we want to be successful. Transparency should always be a top priority. Finding a common definition of the concept I've mentioned should be a great help for this. And a truly patient-centered system is what we are claiming for, and we will keep on claiming for. Thank you.
Thank you very much, Marco, and we will come back to you in the Q&A later. For now, we pass the floor to one other key actor who needs to be on this platform and on this dialogue to the industry, and we go to Natalie. And Natalie, give us a glimpse of your perspective on your role, your responsibilities, what success would look like, and what the pandemic has helped us understand better about these questions.
Thank you so much, Jimmy, and thank you also very much for the invitation. It's really special for me because I was in Gastein 3 years ago on a panel that was discussing access in a very different way. And my one wish at the end was that we would sit around the table and discuss how to move forward. And here we are. we may not be around the same table, but we're around the internet trying to make really constructive proposals. So thank you for that opportunity, and thank you to the WHO for the session. It's really appreciated. I think as Bjorn Inger said very clearly, I mean, the responsibility of industry first and foremost has come to the table with innovations that respond to that unmet medical need that Marco was mentioning. So that's our main job as an innovative industry. That's what we need to do. We need to make sure that we look in areas that require innovation, that we try and find solutions not only to the symptoms, but actually to treat the disease and if possible, cure the disease. And sometimes we're successful and sometimes we are incredibly unsuccessful. You will have noticed that last week was World Alzheimer's Day. And again, for I don't know how many years in a row, we still haven't been able to crack the nut and find a treatment, but still the industry continues to invest and continues to try. And I think it's important to see that not everything that we work in is immediately successful. And therefore the innovation model is not as simple as, adding up some numbers and then finally getting a result. I think there's a 10,000 to 1 probability of success, which is rather small. So that's part of our responsibility. I mean, that's our main responsibility. The other responsibility we have, of course, is coming to the table with facts and knowledge and trying to increase the understanding about what our business model is and where we see hurdles in access. Because if we only create innovation, as Marco was saying, it's kind of pointless if it doesn't reach patients. The whole point is that this innovation is supposed to save lives, make lives better. But that's the whole point. It's not a watch. It's something that everybody relies on. And so we really feel the responsibility of making sure that our innovation reaches patients. And what we've been looking at is what do we see as obstacles? And being very, very concrete. I think over the years, many of you will know that we've been publishing our patient wait indicator, which gives an overview of how long patients wait across Europe for different kinds of innovation. And this year we went a little bit further and we looked, in July, we published a report really analyzing the root causes of these access delays and unavailabilities in order to start that conversation with all stakeholders on how we can find common solutions to the problems. Many of you were mentioning it before, Sarah was mentioning, but also on the previous panel, because we need to start from some facts that we can all agree on. And then we need to sit together, all of us, and find solutions. And I think the most telling difference with the past is that we are no longer discussing about treatments for chronic diseases that will go on for the rest of the patient's life. I mean, that's not the objective, right? The new innovations that are coming are supposed to, if possible, cure, if not, certainly change the pathway of a disease, keep patients out of hospitals, decrease other costs. So they're supposed to have a transformative effect. And yet we sit back and try and discuss as if they were a chronic treatment. And we're never going to square that circle. So and this is why even 3 years ago, we were really calling to have a discussion with all the stakeholders, including patients, hospitals, doctors, nurses, other parts of the industry, healthcare services. How do we introduce incredibly innovative treatments in a system that is made for chronic treatments? And how do we use data? And how do we calculate the reduction in costs in other areas? And how do we save things? And until we sit down and talk about it, it's not enough if industry speaks to regulators or governments. That's not enough. It's really not. It's not enough because the repercussions of the technology are all the way down the chain to the patients, and these things have to be taken into consideration. There was a discussion before about fragmentation of purchasing power, Clemens was referring to, but for me, there's also huge fragmentation of healthcare budgets. So again, we're talking about pharmaceutical budgets when in fact the treatments are no longer pharmaceutical treatments. They are treatments that, Mexican wave the whole system. So the fragmentation of healthcare budgets make it very difficult to optimize expenditure and to optimize outcomes and to optimize investment. And I think you said it, Dimi, when you were saying we're treating, or maybe it was you, Sarah, you were saying today we're funding future patients, but this is not sustainable in the long term. We need to be able to treat patients today and also to make sure that the system is sustainable for the future. So what the COVID-19, so two responsibilities: make innovation and really be part of that dialogue in a very factual manner, in a responsible manner. And it was great to hear the speakers in the first panel recognize this responsibility that came through very evidently during the first 6 months of COVID, and hopefully still now, where we were just in a state of disarray, right? But when solidarity broke down in Europe, it was shocking for all of us, and we could not, as an industry, allow our medicines not to reach patients, right? So we were active in 3 areas: research, we've been doing that, treatments, vaccines. But the first thing is, on the ground in the countries, many of our doctors from companies went to work in hospitals. There were donations of PPE that we had in our companies and monetary donations. And then the other thing was, how do you overcome the stockpiling, export bans, export restrictions? How do you make sure medicines keep moving? And impressive. We're so lucky to have a supranational organizations like the European Union who could help overcome these barriers and this initial sort of knee-jerk reaction by member states, and help us make sure that we could continue the supply of everything. But that really also showed, we had weekly calls with EMA, with the Commission, among stakeholders, really facts on the table. Here there's a problem, how can you fix it? Here's a proposal, can you do this, can you do that? No, we can't do that. Why don't? This is what we need, right? Okay, so that was an emergency, and when there's an emergency, everybody brings out either the best or the worst. People in this case have brought out the best. But I would say that access for patients of innovative medicines is also an emergency. If you're the patient, if your patient is your son, if your mother, your friend, it's an emergency that person gets the medicine. So we should be a little bit more agile and dedicated to sitting together and looking at the problems. So we've published our report. I'm sure there are many other facts from other parts that need to come to the table, and then have that discussion, that joint discussion, and not just a discussion about price or about treatments between governments and companies, because we've had that. Sarah mentioned it. We've had that. We've been there, done that. It doesn't work. For the new treatments, it worked probably for the old, the chronic treatments. That was probably a good way. But today we're not in that space anymore, and we've learned some really hard realities. We've learned some great opportunities through COVID, and why don't we just apply that and move on? So at the cost of sounding really repetitive, we keep calling for a high-level forum, at least at European level, where we can have all the stakeholders on one side of the table, from the patients all the way to the industry, everybody in between, the member states on the other, the Commission as a broker, facts on table, and let's talk about access. Let's make it possible.
Thank you, Natalie, and apologies for my technical problems. I think, Sarah, if you took over the role of the facilitator while I was gone, thank you. Natalie, if you just continue talking, thank you as well. I think we come back to the point during the Q&A, and we move now to our last panelist to give us his input with Audun. Please just give us your perspective on what the real elephants are in this situation and where you stand on the new initiative.
First of all, you challenged me and us, me, on the question, what does success look like? And the big long-term success for me would be a situation where patients and society are offered a steady stream of important new pharmaceuticals, and that it is done in a way that gives real and universal access in a sustainable way for all stakeholders. Just that. But we in Norway, we would really like to give a contribution to the how do we get there question by hosting a meeting, as already mentioned, organized by WHO Euro in Oslo and in the spring of 2022. We would like to discuss how we, and by that I mean all the different stakeholders, can work together to improve the access to new medicines. And in Norway, the important and expensive pharmaceuticals, they are provided by the public, as Bjørn Inge mentioned. Public financing, it's our tax money. This means that we have to be very transparent regarding the way we spend this money. It's absolutely vital for us to have trust in the system. For many of the new medicines that are coming along now, typically the new cancer medicines and the orphan drugs, we really need more information regarding their effect, regarding their value, and we also need more transparency related to prices and also the development costs that haven't been mentioned yet. This is simply to be able to defend the investments and use of the scarce resources. And yes, we do also in Norway have limited resources, so we have to prioritize. We would like to be able to provide a breakdown of costs and to be able to justify the risks by investing in these new pharmaceuticals. And for this reason, Norway calls for increased transparency. And from our side, it's very important that the WHO resolution on transparency from last year, that one is implemented. We're faced with demands for more transparency from different parts of our society, for instance, by our patient organizations. We're faced with it from academia and from politicians. So we need to be able to provide this to justify our system for priority decisions. And of course, we also need this to make the right priority decisions. We believe that we should all be willing to look at the current incentives and reward systems set up for providing society and patients with important innovative medicines and in a sustainable manner. As mentioned earlier, something fundamental must change in our opinion. Our experience is that the current system does not perform good enough in giving patients real access to important new medicines. And we heard the same thing from Austria. It would be really preferable if we, all the different stakeholders, could do this together and look at the problems from different perspectives and with fresh eyes and an open mind. And in preparing for the Oslo meeting and during the meeting, we will try to discuss between the different stakeholders what we can do together to make both the pharmaceutical industry and the health system systems in Europe more sustainable. And here we come to Nastasha's elephants. We will discuss hot topics like, can we agree that it is not a good idea to just continue down the current path, but that we together must try to find new ways forward? And by the current path, I mean the trend we see that we get new pharmaceuticals with less and less documentation, and therefore higher and higher uncertainty. And that is combined with higher and higher prices demand, combined with demand for confidential prices, and combined with no transparency regarding development costs. That's one topic. Another topic is more transparency. Is that a measure that can improve access? Can we agree that transparency is the answer or an answer? And if we assume that more transparency increases and improve access, can we then agree that we must work forward on this? How can we incentivize all stakeholders to be more transparent? Another topic, how can we better share risk and costs related to new products? Are managed entry agreements, or conditional marketing authorization, is that the answer? Or can we figure out also other possibilities and answers? And then we have the old question of fair pricing. Are the expected returns on the investment, is that viable with more explicit risk sharing, which includes probably then also lower prices? And final example, should we as health authorities act more like active buyers than just passive payers? High prices are difficult to justify given the uncertainties regarding effect, touched upon that. Does this need different investment, different purchasing models? some elephants there. I hope this sounds exciting as a teaser to the meeting. And just to finish, as the outcome from the Oslo meeting, we are aiming at having a statement describing how the stakeholders, both private and public, shall work together to enable access to effective high-cost medicines. Thank you.
Thank you very much, Audun. Just to clarify for everyone, these are the big questions for the whole process. They're not the questions for today that we will try to answer now, right? These are just, as you said, a teaser for some of the points you will be bringing to the table on this dialogue, and I'm sure there are many more that will come from the different actors. What I would like to do now, after thanking you all once more for your inputs, would be to ask a question that's been hinted at already in the first part of the panel and already by you, and I think that's on the minds of many of our viewers. We have been discussing these issues. So the three main tenets of the new vision are solidarity, sustainability, and transparency. We've been discussing these issues, not least here at the Gastein forums for the past few years, for quite a long time. So what is it about the current juncture that makes you hopeful that we can actually bring about change this time? And I would like to start with Marco and what you think is now different.
There are a few things, but essential things that are different in these days. One thing is that, well, the COVID has put us in a urgent situation, and this is somehow an accelerator that we may use as an opportunity, because it's a call to work better and to work faster, and also in this field. The second thing is that it's probably a very nice, very interesting conjuncture also for the different stakeholders, because we are, at least it's what we are saying, we are all ready to cooperate. There is a full openness in every stakeholder to work with the others. Patient organization have never been so organized as in this moment. So it's if not now, when?
Okay, thank you very much. Sarah, you are instrumental in bringing this forward. Why now?
Thanks, Timmy. I mean, again, I'd just reflect on what we've seen over the last few months, and just I think with the COVID situation, and it's one of those things that I wonder sometimes if this is something that affects all of us. So that realization has happened that we are all patients, where it's very easy to talk in abstract terms about access, but when it's actually your access yourself, and this has touched every single one of us, this issue. So I think that is a good impetus. We've seen some fantastic examples of new ways of thinking, new ways of working. And for me also, we've been able to get concrete about what needs to change, what needs to happen. And it's always much easier to take things forward when you have those crystals of ideas on which you can grow. So a bit like global warming, it's too big a concept, but when you actually break it down into every individual more recycling or change electric cars, it suddenly becomes a much more reachable target. So I think there's a number of reasons why.
Okay. Audun, do you agree? Because this whole thing, it needs to be said, I think, was conceived before COVID, right before COVID, basically, right? So it's not just a pandemic. Why now?
In my opinion, it's a great opportunity now, because we're in a situation with sort of a double crisis maximization. The first one, we've come to a point where patients do not get real access to new medicines due to high prices, knowledge gap, high risks. It can't continue. That's one crisis. And the second one is then the pandemic, where we have seen new collaboration between the authorities and the industry. So this is a great opportunity to move forward now, while we all are a little shaken and taken out of our usual situation.
Thank you. Natalie, do you agree?
Yeah, I mean, if I can unmute myself. You know, I think this, like I said before, this pandemic taught us that when we need to, we can collaborate. When we need to, we can trust each other. When we need to, we can fix even problems that seem unsurmountable together, but we have to work together. And I think that that is the main difference I've seen. I see questions here around transparency and things like that. Yes, we worked with other industries, but we were brought together. So the Commission brought the different industries that needed to work together. The patients were there, the member states were there, the regulators were there. We were all talking. We weren't talking, you know, in different rooms. We were sitting there together with the facts on the table and trying to fix things as quickly as possible. And clearly it is possible. So for me, that's the biggest learning. The other thing that what would we change? We would change. As a pharma industry, we wouldn't change anything. I mean, in some cases, we had to produce 400 times more than we usually did because we didn't know what the pandemic looked like. What I would change today is to have proper vision on patient needs in countries so that, and that's what we're asking for now, so that we can supply the right amount to the right country, right? No stockpiling, just so we know where we need to send our medicines. But for me, it's not a question of solving a discussion about the price of an innovative medicine. Again, I think we need to be a bit more honest about what the issue is. The issue is introducing innovation for patients for the best outcome into a healthcare system and not a discussion about one product, one price, because who then is paying for the innovation of Alzheimer that still hasn't seen the light of day, you know? It's not about an addition, oh, that's how much it costs in R&D and that's how much you should price it. No, it should be priced the value for the patient. Otherwise, you're gonna have companies investing a lot in R&D to get a huge price. That's not what you want to incentivize. You want to incentivize them getting the best outcome for the patient, and that's where you get rewarded, and best outcome also for the healthcare system. So I think we need to change the conversation, and we can only do that all together around the table, because patients will have a perspective, and you know, the different parts will have, hospitals will have a perspective of what works for them, doctors will have a perspective of what they're missing, and until we do that, we're not going to make much progress. So it's really great to hear the previous speakers talking about sitting down together. It's super encouraging, and I'm really happy that we seem to be all pointing in the same direction. Hopefully we can be as good as we've been in COVID.
Thank you. So I think I'll do two things. I'll encourage everyone to use the Q&A function, and please not the chat function, but the actual Q&A function to ask your questions. I think some of them were already answered by Natalie, and thank you very much for doing that. What I would like to do while you think about what you would like to know from the speakers is ask one more question. And Natalie, this time we'll start with you because you mentioned it already. So we know this is a multifactorial problem. We know this needs a multi-stakeholder solution. And it's not just about individual products or individual issues. And we know that, and we've heard about this also from all of you. And knowing that we now have the beginning of a platform, so it's not just about trying to arrange ourselves to have a dialogue, but we already have that. What is, from your perspective, one wish for this process and one commitment in order to make sure that it is successful?
So my one wish would be that we can put the facts on the table from all sides, but really agree to what are the obstacles to access and what is the objective of access. Is the objective of access having all the most innovative products, or is the objective of access having all patients with the best outcomes? So let's agree. And what are the issues? What are the, so we've published a report, there will be others. Let's sit down. The commitment is to come to the table with new solutions, with different solutions. So for example, you know, we also published in July an overview of the best practices. So the novel pricing and payment methods that many countries use already with our companies to get access to new technologies. Nobody talks about them because they're generally one company, one country. So you're not gonna spend time advertising, but sharing best practice means that other countries could say, oh God, I didn't know that was being done there. That's a clever, you know, oh, they're paying for outcomes, or delayed paying, or paying over a lifetime, or whatever it is. So, you know, really being upfront, and we really commit to come to the table and look at each of the problems that we can agree to together and say, okay, how can we do this differently together with you? And that's a firm commitment.
Thank you. Audun, how do you see that? What's your wish and your commitment for the platform?
From what I've been saying, I guess it's no big surprise that I'll come back to transparency. So my wish is that we can agree on that we need and that we get more transparency. And my commitment would be that we will organize the Oslo meeting and hopefully by that contribute to this.
Okay, thank you. How about you, Marco?
Well, my main wish is that patient organization should not claim for being invited at the table, but should be given a place for granted. And at this table, we need probably to talk about the elephant in the room, and the elephant in the room is money. We shouldn't be ashamed, because sometimes this is the perception, that we are ashamed about talking about money. And if we don't overcome these, we will not find any solution. And for this covers a lot. This covers transparency. This covers to have all the elements of the equation. Otherwise, we will stick there trying to find the solution of the equation. But as you remember from maths at high school, the most factor you know, the easiest the solution it is. So it will be nice. And I give here a short and provocative suggestion of maybe a pragmatic, very pragmatic goal in midterm. We have a very good benchmark for understanding if we are working in the right direction, and it is monitoring shortages. If we could cut 25% of the shortages problem in 1 year, we would be already really near to the solution of our problems. And this is very practical, very easy to be monitored. Thank you.
And Marco, is this your commitment that you will fight for cutting 25% of shortages?
Of course.
Okay. Thank you. Sarah, how about you?
Thank you. So my wish is for personal and organisational courage. If we're going to find solutions, that courage is going to be needed, both in a personal capacity and for organisations to take that leap forward. So that's my wish. And my personal commitment is to keep going. This issue is too important to let drop. So my personal commitment to everybody is to keep going with this and to provide that neutral space to have those discussions.
Thank you very much, Sarah. We have 5 minutes to look at what the audience and how the audience gets engaged with us. I will not pick up on the questions that you already tackled, Natalie. I will go to Albert first and say you focused quite a bit on transparency, and transparency is not just on the price side, it's also on the process side. So we have a question here that asks whether there are any available documents that highlight the Norwegian point of view of your troubles or of your difficulties with funding innovative treatments.
I'm not sure if we have anything written in English, but
okay.
Hopefully through these meetings, through different seminars, and through the meeting and preparation for the meeting in Oslo, everything should become clear regarding this.
Thank you. So this is another, I think, in a way, maybe another commitment on the background, that because we are aiming for transparency, we commit to transparency from all sides to this. So that's an important point. Another point that I have from the Q&A here has to do with the discrepancies we see within Europe, and to what extent the platform and the initiative will be able to tackle issues such as the difference between Western and Eastern Europe when it comes to access to medicines, and how you see that problem at the moment. This is a question that agrees with Marco, but I think this is a question that is open to everyone. So if anyone feels particularly addressed in this, yes, Sarah, please, you can start.
So I'll give this one a go. This is a initiative across all the member states in the region. So the WHO Euro region is much bigger than the EU. In terms of member states, we have 17 middle-income countries and 1 low-income country in the region. If we think the situation's bad in the EU, then we need to look further east just to see the issue. So it touches all of us. So it's something that's on WHO's Euro firmly there on the agenda, and we need to take a broad view when we consider solutions.
Thank you, Sarah. Anyone else from the panel? We have a little bit of a slow Q&A function here.
I think, Jimmy, I think certainly, as Sarah mentioned, it's an issue that is broader, and that's exactly it. The problem of access is exactly what we're trying to crack, the nut that we're trying to crack. And I think, again, a discussion based on the old way of dealing with treatments is wrong. Now the value to patients is different. We can even measure the value to patients. So just using mathematical calculations of R&D costs will incentivize more R&D instead of incentivizing more value. So I think we really need to take into consideration all the progresses that we have, the needs that we have, the fragmented healthcare budgets, be a bit courageous, as Sarah said. It's not going to be the same way we've done things until now. And this is difficult, I understand, but the technology is not the same as it was before either. Now we're looking at underlying causes of disease. We're fixing genes. We're, getting people to avoid operations or curing them. You have to use a different model, and we don't have the model yet. So then let's work on it. But let's not look at the same parts of the equation and try and just use different. It was addition, now subtraction. No, there are new parts of the equation that we need to factor in and great new things. But we need to be a bit brave indeed.
Thank you. Yes, Audun, last word.
But I guess we will never get away from the situation that we need to know the value. It has to be documented. We need to know to make right priority decisions.
But what value? The value to patients? That's I think the question we need to agree on, is the value to patients or the cost? Yeah.
Exactly. So this is what we will be discussing on the platform in the initiative, right? And I think this is what Marco brought in first thing today, saying the most important thing is reaching a common understanding on what we mean when we say the same words, but we mean different things. And I think this is probably one of the key takeaways. We see it in practice, that we need to try to work on it maybe a little bit differently than we've been working on it so far. And I think, Audun, you said fresh eyes, open mind, and probably this is the takeaway message from this panel. So there's going to be a lot of work going forward. The most important thing is to not come in with our entrenched ideas that have been built up over the past many years, but to try for something new. And I think, Sarah, reflecting back to what you said and to our audience, we need participation from all sides to make that truly something that we do together. And as the pandemic showed us, and as you all said, when we really work together, we can do it. So this is what we will try to do also in the following months, to bring everyone on board and have a discussion like this. Thank you all very much. I think we are right on time to wrap up for today, and we look forward to any input from the audience following the session, and to seeing you again very soon on a dialogue platform. Thank you.
Thank you,
Thank you.
Thank you, everyone. Have a good afternoon.